The North African desert stretched endlessly under a merciless sun. July 1943. The Battle of Sicily was about to begin, and in a makeshift field hospital 20 miles behind the lines, a decision was being made that would change military medicine forever. Colonel Edward Churchill stood in the entrance of the surgical tent, his white coat stained with the blood of 100 men. Around him, medical officers rushed between wounded soldiers lying on stretchers that covered every inch of ground. The air was thick with the metallic smell of blood mixed with antiseptic, and the sounds that filled that space, the moans of injured men, the urgent shouts of nurses, the persistent buzz of flies attracted by open wounds. Churchill had seen this chaos before, too many times. In the previous weeks, their survival rate had been devastating. For every 10 critically wounded soldiers who reached their field hospital, only 3 walked out alive. The rest perished, not always from their wounds, but from a system that couldn't keep up with the relentless flow of casualties. That morning, Churchill had made a decision that went against everything he had learned in medical school, a decision that would make him enemies among his fellow surgeons, a decision that, according to traditional medical ethics, was unthinkable. He was going to change how they decided who lived and who passed away. To understand the revolution that Churchill was about to unleash, we must travel back in time to the battlefields of the Napoleonic Wars. There, a French military surgeon named Baron Dominique Larrey had established what would become known as the first modern triage system. Larrey had witnessed the horror of battles where wounded soldiers lay on the field for days with no one to help them. He created the flying ambulances, horse-drawn carriages that rushed to the battlefield while combat still raged. But more importantly, Larrey established a principle that seemed obvious: treat the most seriously wounded first. It didn't matter if a soldier was a general or a private. If a man was bleeding to his end, he received immediate attention. Those with minor wounds could wait. It was a system based on pure medical ethics, the Hippocratic Oath in action. Save the life that is in greatest danger. For more than a century, this remained the standard. During the American Civil War, during the Crimean conflict, through the trenches of World War I, military doctors followed Larrey's principle. The dying came first. But World War I had revealed a dark truth about this system. In the casualty clearing stations behind the trenches of France, British surgeons faced an impossible situation. Thousands of wounded men arrived daily. Injuries from machine guns and artillery shells that previous doctors had never imagined. Wounds filled with mud and shrapnel, infections that spread like wildfire. The surgeons worked around the clock following Larrey's principle. They focused on the most critically wounded, men whose intestines had been shredded by fragments, soldiers whose lungs had been destroyed by poison gas, cases that required hours of delicate surgery. Meanwhile, soldiers with treatable wounds waited and waited. And many of them, who could have been saved with quick intervention, deteriorated. Simple wounds became infected. Manageable fractures led to complications. Men who should have survived didn't make it. By the end of World War I, British military doctors had begun to question the old system. A manual published in 1918 stated something that would have horrified Larrey. The goal of military triage should be, first, the conservation of manpower for combat, and second, the interests of the wounded. Conservation of manpower, not saving lives, returning soldiers to battle. It was a subtle but profound change. Instead of treating the worst cases first, doctors should focus on those who could be patched up quickly and sent back to the front. The critically wounded, those who would require hours of surgery and weeks of recovery, would have to wait. Many doctors rejected this idea. It went against everything they believed in. How could they, as healers, choose to treat a minor wound before a critical one? How could they let a dying man wait while they stitched up someone with a flesh wound? But the numbers didn't lie. When doctors followed the traditional system, treating the worst cases first, the overall survival rate was lower. They spent so much time and resources on patients who might not survive anyway, that other soldiers with better chances passed away while waiting. It was a moral dilemma that haunted every military surgeon of that era. Fast forward to 1943. World War II had been raging for 4 years. The scale of casualties dwarfed anything seen in previous conflicts. In the Pacific, American forces were island-hopping against fanatical Japanese resistance. In Europe, Allied forces were preparing for the invasion of Italy. And in North Africa, Colonel Edward Churchill was facing that same moral dilemma. Churchill wasn't just any surgeon. He had trained at Massachusetts General Hospital, one of the finest medical institutions in America. Before the war, he had been a rising star in thoracic surgery, but the war had changed him, had changed what he believed about medicine. In the months leading up to Sicily, Churchill had witnessed something that shook him to his core. He had watched as his surgical teams performed miracles on critically wounded soldiers. Hours-long operations to repair shredded organs, delicate procedures to remove shell fragments from near-vital arteries, operations that showcased the pinnacle of surgical skill. And then he watched many of those patients pass away anyway, not from their wounds, but from shock, from infections, from complications that developed during those long hours on the operating table. Meanwhile, other soldiers, men who could have been saved with faster, simpler treatment, waited too long. Their conditions deteriorated. Wounds that could have been cleaned and closed became gangrenous. Fractures that could have been stabilized led to deadly infections. The survival statistics haunted Churchill. For every 10 soldiers who reached his field hospital with critical wounds, only 3 survived. It was better than World War I, thanks to blood transfusions and sulfa drugs, but it wasn't good enough. Churchill began to study the patterns. He noticed that survival wasn't just about the severity of the wound, it was about time. A soldier with a severe wound who received treatment within the first hour had a 90% chance of survival. The same soldier, if treatment was delayed 8 hours, had only a 25% chance. Time was the enemy, not the wounds themselves. This realization led Churchill to a controversial conclusion. The old system of triage, treating the worst cases first, was actually causing more harm. By focusing all resources on the most critically wounded, they were creating delays that lowered everyone's survival rate. What if they did it backwards? What if they treated the less severe cases first? Not because those soldiers were less important, but because they could be processed faster. Quick treatment, quick stabilization, quick movement to the next level of care, keep the flow moving, reduce wait times for everyone. The surgeons under Churchill's command were horrified when he first proposed this. One senior surgeon, a man who had served in World War I, confronted Churchill in front of the entire staff. "You want us to ignore dying men while we treat scratches? That's not medicine, that's murder." Churchill's response was cold and calculated. "No, murder is what we're doing now. We're so focused on saving the unsavable that we're letting the savable perish. I'm not asking you to ignore anyone. I'm asking you to be more efficient." The argument that followed nearly split the medical team. Some supported Churchill's radical approach. Others threatened to report him to the Surgeon General. The tent hospital became a battleground of its own, a war of medical philosophies playing out while the actual war raged just miles away. But Churchill had one advantage. He had data. In a field hospital operating under traditional triage, the survival rate for all categories of wounded was approximately 30%. Churchill had access to reports from German medical units that had experimented with reverse triage, prioritizing lightly wounded soldiers for rapid return to duty. Their overall survival rates were higher, not dramatically higher, but measurably better. The Germans, however, had used reverse triage for a different reason, to return soldiers to combat quickly. Churchill wanted to use it for a different purpose, to save more lives overall by reducing wait times and preventing deterioration. He also had another weapon in his arsenal: penicillin. The story of penicillin is one of the great medical miracles of World War II. Discovered by Alexander Fleming in 1928, the antibiotic had languished in laboratories for over a decade. No one could figure out how to mass produce it. It remained a scientific curiosity, a mold that killed bacteria in Petri dishes, but couldn't be manufactured in quantities useful for treating patients. Then came the war. The urgent need for better treatment of infected wounds drove a massive research effort. In American laboratories, scientists worked day and night to solve the production problem. They tested different strains of the penicillium mold. They developed new fermentation techniques. They experimented with packaging and dosing. The breakthrough came from an unlikely source. A researcher found a strain of penicillium growing on a cantaloupe in a lunchroom at an agricultural research center in Illinois. This strain produced far more penicillin than any previous variety. By 1943, enough penicillin was being produced to supply military hospitals in North Africa. It arrived in Churchill's field hospital in small glass vials, a clear yellow liquid that seemed almost magical in its effects. Before penicillin, infections had been the great killer of wounded soldiers. A man could survive the initial trauma of a bullet or shell fragment, only to pass away days later from gangrene or sepsis. Sulfa drugs had helped, but they were inconsistent and had serious side effects. Penicillin changed everything. A wound that would have become fatally infected could now be treated with a simple injection. The transformation was so dramatic that surgeons who had been treating infected wounds for years could hardly believe what they were seeing. One British surgeon with the 21st Army Group later recalled his amazement. Before penicillin, he and his colleagues had rushed down lines of wounded soldiers, tearing off dressings in a crude and painful form of triage, looking for wounds that weren't already too infected to treat. It was a desperate, brutal process. But after penicillin became available, that surgeon noted that he could wait to inspect a wound until the patient was on the operating table. The soldiers treated with penicillin were remarkably comfortable. Their wounds were painless. Their recovery was swift. The statistics told the story. In World War I, the survival rate for wounded soldiers had been approximately 4%. By 1944, with penicillin widely available, the survival rate had jumped to 50%. But Churchill realized that penicillin alone wasn't enough. The drug was a game changer, yes, but it couldn't fix a broken system. Wounded soldiers were still waiting too long for treatment. The bottleneck in the surgical tents was still causing unnecessary fatalities. He needed to implement his controversial triage system, and in July 1943, he finally had the authority to do it. The first test of Churchill's backwards triage system came during the Allied invasion of Sicily. Operation Husky was one of the largest amphibious assaults in history. Over 160,000 Allied troops landed on the beaches of Sicily, facing determined German and Italian resistance. The casualties were staggering. In the first 3 days of the operation, over 2,000 Allied soldiers were wounded. They came flooding into Churchill's field hospital in waves, men with gunshot wounds, soldiers who had stepped on mines, burns from flamethrowers, the full horror of modern warfare. Under the traditional system, Churchill's medical team would have focused first on the most critically wounded, the soldier with the sucking chest wound, the man whose leg had been nearly severed by shrapnel, the burn victim who had lost most of his skin. But Churchill implemented his new system. The medical officers at the triage point were instructed to sort casualties into 3 categories, not by severity, but by treatment time. Category 1, wounded, who could be treated in under 30 minutes. Flesh wounds that needed cleaning and suturing, simple fractures that could be splinted, moderate burns that required dressing. Category 2, wounded who needed 1 to 3 hours of surgery, compound fractures, deep tissue damage, wounds requiring debridement and possible amputation. Category 3, the critical cases, soldiers requiring extensive surgery, 3 hours or more. The traditional first priority cases. The Category 1 patients went through first, rapid treatment, quick doses of penicillin, clean the wound, close it up, inject antibiotics, move them to recovery. The surgical teams worked like assembly lines. Each doctor handled one type of injury. One specialized in sutures, another set fractures. A third team handled burns. It was efficient, almost cold in its efficiency. A soldier would arrive at the triage point, be assessed in seconds, then move to the appropriate treatment area. If he was Category 1, he'd be through the system in 20 minutes, bandaged, medicated, and sent to a recovery tent. The Category 2 patients followed. These required more time, but the surgeons worked with a new focus. No lengthy, complex procedures. Stabilize the patient, control bleeding, prevent infection, do what's necessary to make them stable for evacuation to a base hospital in the rear. Save the complicated procedures for later, when the immediate crisis had passed. Only after the first two categories had been processed did the surgical teams turn to Category 3, the critical cases. By this point, hours had passed since these soldiers had arrived. Under the old system, they would have been treated first. Under Churchill's system, they waited. This was the moment that would determine if Churchill's gamble would pay off or if he had just condemned men who could have been saved. The results shocked everyone, even Churchill himself. In the first week of Operation Husky, Churchill's field hospital treated over 800 wounded soldiers. The survival rate was 71%, not 30%, as it had been under the traditional system, 71%. More than twice as many soldiers survived. The reason was simple but revolutionary. By treating the less severe cases first, Churchill's team had dramatically reduced overall wait times. A soldier with a moderate wound no longer deteriorated while waiting for treatment. He received care within the first critical hour, when survival rates were highest. The Category 2 patients, those needing more extensive surgery, also benefited. The surgical teams were fresher, having spent the first few hours on quicker, easier procedures. They weren't exhausted from marathon operations on the most critical cases. They could focus better, work more efficiently. Even the Category 3 patients, paradoxically, didn't fare worse. In fact, many of them survived longer than they would have under the old system. Why? Because they received better stabilization care while they waited. Churchill had established what he called shock wards. These were areas where critical patients received aggressive resuscitation while waiting for surgery. Trained nurses administered blood transfusions. They gave plasma to combat shock. They monitored vital signs constantly. They injected penicillin to fight infection. The shock ward concept was crucial. It meant that waiting wasn't passive. Critical patients weren't just lying on stretchers getting worse. They were being actively managed, their conditions stabilized, their bodies prepared for the eventual surgery. Churchill had discovered something profound. Surgery itself was a form of resuscitation, but it wasn't the only form. Sometimes the best thing a surgeon could do wasn't to operate immediately, but to ensure the patient was as stable as possible before the first incision. One case illustrated this perfectly. A soldier named James Connell had arrived at the field hospital with a severe abdominal wound. Shrapnel had torn through his intestines. Under the traditional system, he would have gone straight to surgery. Under Churchill's system, he went to the shock ward. For 2 hours, nurses worked on him. They gave him blood. They treated his shock. They stabilized his blood pressure. They administered penicillin to fight the infection already taking hold. By the time Connell reached the operating table, his condition had improved dramatically. The surgery was still complex, still dangerous, but the surgeon wasn't operating on a patient in shock. He was operating on a patient whose body had been given a fighting chance. Connell survived. He recovered and was eventually evacuated to a hospital in North Africa, then to a facility in England. He made it home after the war. Under the old system, he almost certainly would have passed during or immediately after surgery, his body too weak to handle the trauma of the operation. Stories like Connell's multiplied. As word of Churchill's success spread through the medical corps, other field hospitals began adopting his methods. The backwards triage system, initially controversial and denounced by traditionalists, became standard practice. By 1944, when Allied forces landed on the beaches of Normandy on D-Day, Churchill's system was in full effect. Combined with the widespread availability of penicillin, the results were nothing short of miraculous. On Omaha Beach, the bloodiest of the D-Day landings, medics treated thousands of wounded men under the most horrific conditions. The beach was swept by machine gun fire. Artillery shells fell continuously. The wounded lay in the surf, in the sand, behind obstacles, waiting for help. The medics who reached them worked according to Churchill's principles: rapid assessment, quick treatment for those who could be stabilized fast, morphine for pain, sulfa powder on wounds, tourniquets for severe bleeding. Then move on to the next casualty. The more severely wounded were tagged and carried to aid stations just off the beach. There, in underground bunkers reinforced with sandbags, doctors performed triage again. Category 1 patients went through quickly. Category 2 and 3 were stabilized and prepared for evacuation. Penicillin was administered liberally. Every wounded soldier received a dose as soon as possible. The effect was dramatic. Infections that would have claimed thousands of lives in previous wars were prevented. Wounds that would have turned gangrenous healed cleanly. The survival rate for D-Day wounded was astonishing. Approximately 97% of soldiers who reached a medical facility alive survived their wounds. This was unprecedented. Never in the history of warfare had such a high percentage of wounded soldiers been saved. Churchill's system, combined with penicillin and improved evacuation methods, had created what military historians would later call the golden hour of trauma care. Get a wounded soldier to medical care within 1 hour, and his chances of survival soared. But the story of Churchill's backwards triage isn't just about statistics and survival rates. It's about the personal cost of these decisions, the moral weight carried by the doctors and nurses who implemented this system. Dr. Sarah Mitchell was a nurse in Churchill's field hospital during the Sicily campaign. In her diary, which was later published, she wrote about the anguish of the new triage system. One entry from July 1943 described a night when 2 soldiers arrived simultaneously. One had a severe chest wound. The other had multiple fractures and lacerations, but wasn't in immediate danger of passing. Under the new system, Mitchell was instructed to focus on the second soldier first. She wrote, "I looked into the eyes of the man with the chest wound. He knew. He knew that under the old rules, he would have been first. He didn't complain. He didn't cry out. He just looked at me with this terrible understanding. I wanted to tell him it wasn't about his value as a human being. It wasn't that we cared less about him. But how do you explain that to a man who's struggling for every breath?" Mitchell treated the other soldier, cleaned his wounds, set his fractures, administered penicillin. It took 40 minutes. Then she returned to the chest wound patient. He was still alive, still waiting. She got him to the shock ward. The nurses there worked on him for hours. When he finally made it to surgery, the operation was successful. He survived. Mitchell ended that diary entry with a question that haunted many medical personnel. Did we do the right thing? His survival suggests yes. But what about the ones who don't make it while they're waiting? How do we live with those decisions? This moral complexity was something Churchill himself struggled with. In reports he submitted to Army Medical Command, he acknowledged the ethical challenges of reverse triage. He argued that it was justified not by individual cases, but by overall outcomes. More soldiers survived. That was the metric that mattered. But he also recognized that this utilitarian approach came at a psychological cost. Doctors and nurses who had been trained to prioritize the most critically ill found it deeply disturbing to make them wait. Some medical personnel requested transfers rather than work under the new system. Others suffered from what we would now recognize as moral injury, the psychological damage that comes from being forced to act against one's core values. Churchill established regular debriefing sessions for his medical staff. He encouraged them to talk about their feelings. He acknowledged that what they were doing was hard, but he also reminded them of the numbers. Under the new system, more soldiers went home, more families got their sons and brothers back, more lives were saved. It was cold comfort for those who had to look into the eyes of a dying man and tell him to wait. But it was the truth. As the war progressed, Churchill's backwards triage evolved and improved. Medical teams developed better protocols for stabilization, The shock wards became more sophisticated, with better equipment and more trained personnel. Surgical techniques improved, allowing for faster operations without sacrificing quality. The introduction of air evacuation also transformed the system. Instead of relying on ambulances that took hours to reach rear hospitals, wounded soldiers could be flown out in aircraft. A journey that once took 2 to 3 days by ship now took 4 hours by air. This rapid evacuation meant that field hospitals could focus on stabilization rather than definitive care. Patch them up, get them stable, put them on a plane, let the fully equipped hospitals in the rear handle the complex procedures. By late 1944, the survival rate for American wounded in Europe had reached unprecedented levels. The combination of rapid triage, effective antibiotics, skilled surgery, and quick evacuation created a system that saved lives on a scale never before seen in warfare. The Pacific Theater saw similar improvements, though the challenges there were different. The jungle environment meant that evacuation took longer. The heat and humidity made infections more common. But the principles of Churchill's system still applied. Rapid assessment, quick treatment for those who could be processed fast, aggressive stabilization for the critical cases, liberal use of antibiotics. One particularly innovative application of reverse triage occurred during the Battle of Okinawa in 1945. The fighting on Okinawa was some of the most brutal of the entire war. The Japanese defenders fought fanatically, and American casualties were staggering. Medical units on Okinawa adapted Churchill's system to the unique conditions of the battle. They established multiple triage points closer to the front lines. Corpsmen performed initial assessment right in the combat zone, tagging casualties according to treatment time rather than severity. This allowed for faster processing at the field hospitals, which were often just a few hundred yards from active fighting. The results spoke for themselves. Despite the intensity of the combat and the horrific nature of the wounds, the survival rate for Americans on Okinawa remained high. Medical personnel saved thousands of lives that would have been lost in previous wars. Among those medical personnel was a conscientious objector named Desmond Doss, a medic who refused to carry a weapon but who braved enemy fire repeatedly to rescue wounded soldiers. In one extraordinary effort, Doss single-handedly saved approximately 75 men by lowering them down a cliff face to safety using a rope and a simple knot system. He would later receive the Medal of Honor for his actions. Doss's story illustrated another aspect of Churchill's system. The medics and corpsmen on the front lines were empowered to make triage decisions. They were trained in the principles of rapid assessment and stabilization. They understood that their job wasn't just to keep a soldier alive until he reached a doctor. Their job was to provide treatment that fit into a larger system designed to maximize overall survival. This decentralization of medical authority was revolutionary. In previous wars, medical care had been rigidly hierarchical. Medics provided basic first aid. Doctors made all the important decisions. But in World War II, particularly under Churchill's influence, medics were given more responsibility and more training. They became true medical professionals in their own right. The war in Europe ended in May 1945. The war in the Pacific ended in August, and as the guns fell silent, military medical personnel began to assess what they had learned. The statistics were remarkable. Of American soldiers wounded in action during World War II, approximately 50% survived. This compared to 4% in World War I. The improvement was so dramatic that it seemed almost impossible, but it was real. The reasons for this improvement were multiple: penicillin and other antibiotics, better surgical techniques, blood transfusions, improved evacuation methods. But at the heart of it all was Churchill's backwards triage system. By challenging the traditional approach to battlefield medicine, by prioritizing efficiency over conventional ethics, Churchill had created a system that saved tens of thousands of lives, perhaps hundreds of thousands. The exact number is impossible to calculate, but the impact is undeniable. In the years after the war, Churchill's work became the foundation for modern trauma care. The principles he established, rapid assessment, treatment based on time, required rather than severity, aggressive stabilization, swift evacuation, became standard in civilian emergency medicine. When you go to a modern emergency room, you experience a version of Churchill's system. The triage nurse who assesses you when you arrive isn't asking how badly you're hurt. They're asking how quickly you need to be seen. A heart attack patient goes back immediately, not because their suffering is worse than someone with a broken bone, but because they need treatment within minutes to survive. The ambulance system, the trauma centers, the protocols for mass casualty incidents, all of these descend directly from the innovations of World War II military medicine. Churchill's backwards triage was the spark that ignited a revolution in emergency care. But what about the ethical questions? Did Churchill's system truly violate medical ethics, or did it represent a higher form of ethical thinking? Medical ethicists have debated this question for decades. Some argue that Churchill's approach was fundamentally utilitarian, sacrificing the interests of individuals for the greater good. Under this view, every patient deserves maximal effort, regardless of the impact on others. To do otherwise is to treat people as means to an end, rather than as ends in themselves. Others argue that Churchill's system was actually more ethical because it saved more lives overall. In a resource-limited environment, like a battlefield, perfect care for everyone is impossible. The question isn't whether to make trade-offs, but how to make those trade-offs in the way that does the most good. Churchill himself addressed this in a paper he published after the war. He wrote, "The goal of military medicine is not to provide perfect care to each individual patient. It is to maximize survival across all patients. When resources are unlimited, these goals align. But on the battlefield, they often conflict. A doctor who spends 6 hours saving one life while 10 others pass away from lack of attention has failed in his duty, not because he didn't try hard enough, but because he didn't think broadly enough. One must." This perspective represents a shift from the traditional medical focus on the individual patient to a public health perspective that considers populations. It's the same ethical framework that guides decisions about vaccination programs, resource allocation in healthcare systems, and responses to pandemics. The COVID-19 pandemic brought these questions into sharp focus once again. When hospitals became overwhelmed with patients, doctors had to make triage decisions reminiscent of battlefield medicine. Who gets the ventilator? Who gets the ICU bed? In many cases, the answers weren't based on who was sickest, but on who had the best chance of survival with treatment. These are the same calculations Churchill made in 1943, the same difficult choices, the same moral weight. The difference is that Churchill's system was implemented in the context of war, where the trade-offs are perhaps more obvious and more accepted. In civilian medicine, we still struggle with these questions. We want to believe that everyone gets equal treatment, that medical care is based purely on need. But the reality is more complex. Churchill's legacy is a reminder that sometimes the most ethical choice isn't the most obvious one. Sometimes saving more lives means being willing to challenge traditional approaches and accept uncomfortable trade-offs. Colonel Edward Churchill returned to Boston after the war. He resumed his position at Massachusetts General Hospital, where he continued to teach and innovate in thoracic surgery. He rarely spoke publicly about his wartime experiences, but those who worked with him noted a certain weight he seemed to carry, the burden of having made thousands of life-and-death decisions. He passed away in 1972 at the age of 77. His obituaries mentioned his contributions to surgical technique and medical education. They noted his service during the war, but they rarely emphasized his most important innovation, the backwards triage system that saved so many lives. Perhaps this is fitting. Churchill himself never sought credit for the system. In his writings, he emphasized that it was a team effort, the result of countless medical personnel working together, trying different approaches, learning from failures. But history recognizes his central role. Medical historians credit Churchill with revolutionizing battlefield medicine. His reports from North Africa became required reading at military medical schools. His principles were incorporated into NATO medical doctrine, Soviet military medicine, and eventually civilian emergency medical systems worldwide. Today, when a paramedic assesses multiple car accident victims and decides who to transport first, they're using Churchill's system. When an emergency room handles a mass casualty event and sorts patients by treatment time, they're following his protocols. When trauma surgeons focus on damage control rather than definitive repair in the initial surgery, they're applying his philosophy. The backwards triage system, once controversial and condemned, is now so embedded in medical practice that most healthcare providers don't even realize they're following a protocol developed on the battlefields of World War II. There's a memorial in Sicily, near the beach, where Allied forces landed during Operation Husky. It's a simple stone marker that lists the names of soldiers who fell during the campaign. Thousands of names, each representing a life cut short by war. But for every name on that memorial, there are 2 or 3 soldiers whose names aren't there. Soldiers who were wounded, who should have become names on a memorial, but who survived instead, who went home, who lived full lives, who had children and grandchildren. Many of those survivors owe their lives to a controversial decision made by a surgeon who dared to challenge tradition, who understood that sometimes the best way to honor the value of every life is to think about saving the most lives, even when that means making difficult choices about who receives care first. Churchill's backwards triage saved tens of thousands of soldiers during World War II, but its impact extends far beyond that conflict. It transformed how we think about emergency medicine. It established principles that continue to save lives every single day in hospitals and ambulances across the world. The story of backwards triage is a reminder that progress often comes from questioning what everyone believes is true, from being willing to challenge conventional wisdom, even when that challenge is uncomfortable, from having the courage to make difficult decisions and accept the moral weight of those decisions. It's also a story about the nature of ethical thinking in medicine. Is it more ethical to focus all resources on the patient in the greatest need, or to distribute resources in a way that saves the most lives overall? There's no easy answer to that question. It depends on your values, your philosophical framework, your understanding of what medicine should be. What we can say with certainty is that Churchill's system saved lives, many lives. And in the end, perhaps that's the most important measure of all. The North African sun is setting now, casting long shadows across that desert where 80 years ago a medical revolution began. The field hospitals are gone. The wounded soldiers have either recovered or passed into history. But the legacy remains, embedded in every emergency room protocol, every paramedic training manual, every combat medic's field guide. Colonel Edward Churchill's backwards triage method didn't just save 70% more wounded soldiers during World War II. It changed medicine forever. And every person who walks into an emergency room today, every patient who survives a mass casualty event, every victim of an accident who receives the right care at the right time, benefits from the system he created. It's a legacy written not in stone monuments or public memorials, but in the lives saved, in the families reunited, in the futures made possible. And that, in the end, is the greatest monument any doctor could ask for. The sun sets over Sicily. The desert winds blow across North Africa. The beaches of Normandy lie peaceful in the twilight. And the echo of Churchill's revolution continues, saving lives, challenging assumptions, reminding us that sometimes the greatest courage isn't found in following tradition, but in daring to imagine a better way.